Hello, everyone. My name is Dr. Michael Martin. I am the Senior Medical Director at IPSA Pharmaceutical in Parsippany, New Jersey. Here today, I will be talking to you about our topical pain therapy, which includes Flector and Licart. We commercialize both Flector and Licart. The active ingredient is diclofenac. However, in today's presentation, I will be speaking specifically about Licart, the efficacy, the safety, and also how it applies to individuals with acute pain today. So firstly, Licart and Flector, just to go over the indication and then through the ISI. So Licart is indicated for adult patients with acute pain due to minor strains, sprains, and contusions, as well as those patients who has acute pain exacerbations. Flector is indicated for those patients who have acute pain due to minor strains, sprains, and contusions, but is indicated for those who are 6 years and older. So that's the difference. Flector is given or administered twice a day on a BID schedule, and Licart is a once-a-day patch. So in looking at this box warning that you see, this box warning is typical of all NSAIDs. And you see the cardiovascular thrombotic events and the GI bleeding. NSAIDs have been the treatment of choice for inflammation and acute pain, but it has its drawbacks. So when we start talking about the oral NSAIDs, when we start thinking about adverse reactions, adverse events, you're thinking about the cardiovascular, you're thinking about hepatic and renal injury and the antiplatelet effects, as well as the GI bleeding. But also what sometimes people don't think about is the systemic exposure, the amount of the active ingredient diclofenac that is actually within the bloodstream. And later on throughout the slide deck, you will see why this is important when we start talking about systemic exposure. Next, when looking at topical NSAID gels and liquids, they also have additional drawbacks. So for instance, a lot of the topical NSAID gels and liquids, they're indicated for osteoarthritis or not indicated for acute pain. That's where we're different. Licart is indicated for acute pain. But not only that, you start looking at the onset of action. So the onset of action of the gels and liquids typically are longer. It can take hours to days before you get that full potential effect. Sometimes what happens is you have to apply it more than once. You apply it, then you have to wait for it to dry before you apply your clothing, and that can be cumbersome, as well as sometimes there is odor. So with our Licart, is only applied once a day. It's a once-a-day application. It's a patch, and there is no odor, and it isn't messy. So you apply it to your skin or wherever the acute pain is, and that's it. So despite the drawbacks, the new clinical guidelines call for the first-line use of topical NSAIDs. So according to the ACP, as well as the American Academy of Family Physicians, what they have recommended is for acute pain, for non-low back pain, musculoskeletal injury, that non-steroidal anti-inflammatory drugs with or without menthol be used as first-line therapy. So, and this came with a very strong recommendation. So when talking about Licart, let's begin. So Licart, as I said, is commercialized and produced by IPSA Pharmaceutical. It was FDA approved in December of 2018. We just launched Licart in November of last year of 2020. And I already mentioned it's a once-a-day topical patch. What I'm going to talk about now, how it differentiates itself basically from our Flector patch. So it has two unique delivery systems. So let's start with the picture on the left, which is representative of the Flector. So the Flector consists of an outer and inner layer, and it's all enmeshed in a hydrogel. The blue circles you see represents the active ingredient, the diclofenac. And what happens is with the traditional Flector patch, you see a diffusion of the diclofenac through the skin to the pain site. What happens is the inactive ingredients, there are 17 inactive ingredients, they remain outside of the skin, and only the active ingredient, diclofenac, transverses the skin. If we move closer to the right, this represents the Licart topical system here. It's different because I mentioned earlier that there are two systems that allow the diffusion of the active ingredient through the skin. So let's back up. So Licart has 18 inactive ingredients. And what happens is they form what they call a diclofenac enhancing agent. And that consists of these large molecules that have a high, very large electronegativity. And what happens is you have a smaller diclofenac apolamine molecule that also is electronegative, but you have the larger one actually propelling and pushing the smaller diclofenac apolamine faster to the skin, and that is what penetrates the skin. So the diclofenac apolamine penetrates the skin, but because of this diclofenac enhancing agent with this huge electronegativity, it is propelled faster, and a larger concentration of the diclofenac actually is expelled to the acute pain site. So that's how the two systems are different from the Licart versus the Flector. This is important because when we go through some of the clinical studies, I will call your attention to a quicker onset of action. So this is what happens here. So this study was composed of 233 patients. It was a randomized double-blind placebo-controlled study, and it looked at patients with ankle sprains, and it followed them over 7 days. And what this is really telling us is that over the 7 days, we first saw a reduction in pain as early as the first hour, and this continued all the way throughout the study. But we saw early onset of pain relief the first 1 to 3 hours. This is unlike some of the other topicals that you see out there. As I mentioned, they take hours to days because they have to get within a certain, you have to get to a certain Cmax, maximum concentration within a certain time frame, but normally it's longer than the first 1 to 3 hours. So in this study, it was statistically significant as early as the first, and it continued throughout. Another important thing is when a patient is on a pain medication, you know what, you want to have not only sustained pain reduction, but you want to have continued relief of that pain. So this is the same study, but this was a secondary endpoint. So what happened was these patients were followed, they were either randomized to placebo or Licart. And what we see is here, we see sustained pain for the entire 7 days. And this is following administration of the Licart patch, once a day patch, consecutively over the 7-day period. And what you can see here by looking at this graph here, you can see not only sustained, but we saw improvement, more of a reduction in the pain over those 7 days. In this study here, it was a study consisting of 185 patients who had mild to moderate contusions, as well as complicated by a hematoma. So again, this was also a secondary endpoint, but what we saw was those patients who were randomized to Licart versus placebo, they were less likely to use a rescue medication. The rescue medication here that was allowed was ibuprofen up to 1.2 grams a day. Also, I want to mention that not only did we see a reduced use of rescue medication, but we also saw a reduction in the hematoma within the same time frame. So I mentioned when I was talking about the box warning, some of the things that you see or expect with oral NSAIDs. So for instance, the cardiovascular warnings, the hepatotoxicity, the renal insufficiency, but also I had mentioned something about systemic exposure. So what we see is with systemic exposure, the higher systemic exposure, the more likely you're going to have adverse reactions, which would be the side effects, the ones that I had just mentioned. So what we're looking at right here is you're looking at the Cmax of the diclofenac 50 milligram tablet on the left, and then moving to the right, you see the topicals. And what this slide actually talks to is that both Flector and Licart has a lower systemic exposure compared to the other topicals, and definitely compared to the oral diclofenac tablets. So this again tells you that Licart and Flector not only has a low systemic exposure, but is less likely to interfere or cause adverse reactions. So a lot of times individuals want to know, if I add another pain medication, on top of this, is there going to be adverse reaction? You know what? Because topicals have such low, in general, have such low systemic exposure, chances are there would not be. However, you as the clinician, you have to weigh the risk with the benefits and decide what works best for your patient. On this slide, what we're doing is we're looking at adverse events. So the most common adverse events that occur were application site reactions, more specifically pruritus. And what you see here is when you look at placebo, it was non-statistically significant. However, in looking at it, look at the numbers. So numerically, you can see that those side effects, those adverse events that occurred with the Licart were extremely small, even to placebo. But again, it was not statistically significant. But what I'm saying is you want a product that is, it's going to be comparable to placebo with regards to causing or exhibiting adverse reactions. So in summary, what have we seen? We have seen that with Licart, it's a once-a-day formulation. You apply the patch once a day. We have seen early onset of pain relief as soon as the first hour, and this continued throughout 7 days, as long as you applied the patch consecutively. We've seen sustained pain relief. And not only that, but we've also seen a reduction in inflammation, which was also shown as a secondary endpoint on some studies. I didn't show it here, but it was one of the secondary endpoints on some studies. But we also saw that with Licart, you not only did you see the acute reduction in pain, but we saw also improvement of physical function. And that was exhibited as secondary endpoints in our studies too, in terms of pain upon movement, pain at rest. We saw a reduction in edema, and we know what that occurs when you have a reduction in inflammation, you're going to have a reduction in edema, you're going to have a reduction in pain. We also saw studies that showed that there was less need to use a rescue medication when those patients were on the Licart topical system versus the placebo. It can be used as monotherapy or as add-on. In terms of safety and tolerability, I went through the box warning and showed you that this box warning is typical of all NSAIDs, oral or topical. However, due to the low systemic effect of the topicals, and more specifically, Flector as well as Licart exhibited a lower systemic exposure than the other topicals. But we also saw when we looked at adverse reactions, the most common was application site reactions, more commonly being pruritus. Once again, it's dosed once a day. Thank you for listening to the presentation. And if you have any questions, please let me know. We have a couple minutes, so any questions at this time? One thing I will bring up that people often ask is they will say, well, can I cut the patch? So although the package insert prescribing information clearly says do not cut the patch, we have done studies in our global headquarters that have shown that if you cut the patch, the diclofenac epolamine, the concentration is the same in each section. So for instance, this study looked at one diclofenac epolamine patch, and it was subdivided into 6 portions and followed at over 24 and 48 hours. And what we saw was the concentration of the diclofenac epolamine remained the same in each of the same subsections. So again, it is not recommended to cut the patch, but if you did, you would get the same concentration of diclofenac epolamine. One other thing that I'll bring up too, since we do have 1 minute, with regards to applying the Licart patch, as I mentioned, you attach the patch, but if you tend to attach it over mobile joints, you can adhere it with a gauze, and that will help affix it to the mobile joint and keep it within on the system for at least 24 hours. Thank you very much for listening to me, and enjoy the rest of the presentations.
Good evening, everyone. Welcome and thank you for joining us. And thank you for that message from our sponsor. I am Dr. Lisa Witkin, your host for this evening. I am Site Director of Pain Management at New York Presbyterian Lower Manhattan Hospital at Weill Cornell Medical College, and also a board member of the Eastern Pain Association. Tonight's program is Innovations in Research. We will have 6 15-minute subject matters representing compounds currently in phase 2 or 3 clinical trials, or that have been submitted for FDA regulatory approval, each representing a novel approach compared to standard of care products. These will be presented by academic researchers, not company representatives, using publicly available information. Next slide. This is the educational CME information for your reference. And now I would like to introduce our moderators for this evening's program, Dr. Schmidt and Dr. Interisi. Dr. William K. Schmidt is president of North Star Consulting, LLC, and also the parliamentarian of the Eastern Pain Association, as well as a past president and Benica awardee. Dr. Charles Interisi is professor of pharmacology at Weill Cornell Medical College, and is also a past president of the EPA and current board member. So now I will turn it over to them.
Hi, this is Bill Schmidt, and it's really my pleasure to introduce the first few speakers on this program. But I also wanted to thank everyone who's joined us today to talk about innovations in research. This is a program that Chuck Interisi and I started to put together many years ago. In fact, I think it goes back about 18 years total. And each time we have a chance to introduce new medications that are in development, and we'll see as some of them progress through development and get approved by the FDA, not all of them will, but we are all looking for innovations in pain medicine so that we can do our job better in treating patients. So our first speaker today is going to be Nima Yazdantana, who is in physical medicine and rehabilitation at SUNY Downstate. He's also on the social media committee of the Eastern Pain Association, a member of the American Academy of Pain Medicine trainee committee. He's also in the secretary of the New York Society of PM&R Executive Board and the founder and CEO of Inner Peace Medicine. And Dr. Yazdantana is going to be talking about chemotherapy-induced peripheral neuropathy and highlighting a new program, a new drug for this particular indication. Nima?
Thank you so much for the introduction. As mentioned, my name is Nima Yazdantana, and I would like to discuss how Neuron for chemotherapy-induced neuropathic pain. I have no financial relationship to disclose. Chemotherapy-induced peripheral neuropathy develops in up to 80% of cancer patients receiving cytotoxic chemotherapeutics, and its severity and pathophysiology is dependent on the class of anti-epileptic agents, dose, and duration of treatment. Neuropathic pain develops in up to 40% of these patients and often persists after termination of treatment. Impairment of peripheral neurons by anti-cancer agents, including taxanes and platinum derivatives, is considered to be a major cause of chemotherapy-induced peripheral neuropathy. Chemotherapy-induced peripheral neuropathic pain is a serious side effect that compromises patients' quality of life and leads to chemotherapy dose attenuation at the expense of survival. A 2014 study by the American Society of Clinical Oncology reviewed 48 randomized clinical trials for chemotherapy-induced peripheral neuropathy. The committee found no drugs to be efficacious at chemotherapy-induced peripheral neuropathy prevention. Moreover, there are currently no FDA-approved treatments for neuropathic pain resulting from chemotherapy. At the moment, about 93% of cancer-related pains drugs are opiates. Furthermore, current treatments using anti-epileptics, antidepressant, and opiates have shown to be inefficacious in treating chemotherapy-induced neuropathic pain. Halneuron is WEC's pharmaceutical product currently under development, which has emerged as a potentially efficacious analgesic without the opiate side effects for chemotherapy-induced neuropathic pain. Halneuron's active pharmaceutical ingredient is tetrodotoxin, a potent neurotoxin known to block voltage-gated sodium channels, inhibiting the initiation of and conduction of nerve impulses in the peripheral neurons associated with pain. Tetrodotoxin's name draws from Tetra odontiform, an order that includes pufferfish and other marine and terrestrial animals. Tetrodotoxin is produced by certain infecting or symbiotic bacteria found in animals such as Pseudomonas and Vibrios. Tetrodotoxin or TTX have been extensively used to elucidate the role of specific voltage-gated sodium channel subtypes in a wide range of physiological and pathophysiological processes in the nervous system. Tetrodotoxin, as mentioned, is a voltage-gated sodium channel blocker. The mechanism of action via which TTX exerts its pain-relieving properties is related to the compound's ability to inhibit the movement of sodium ions through the sodium channels required to the initiation and conduction of nerve impulses at the periphery. Both peripheral nerves and dorsal root ganglions contain sodium channels that are sensitive to TTX blockage. Tetrodotoxin inhibits the firing of action potential in neurons by binding to the voltage-gated sodium channel in nerve cell membrane, reducing abnormal neurons activity and that results into pain and eventually pain relief. There is evidence that TTX treatment reduces the aberrant nerve impulses in hyperactive, damaged peripheral nerves going up to and including the dorsal root ganglion.
In persistent and chronic pain conditions, long-term changes occur in the functioning of pain nerve cells, making them highly sensitive and active, a phenomenon known as sensitization. The sodium channels located on nerve cells are in part responsible for sensitization. They act as gates that regulate the entry of sodium ions across the cell membrane and play a critical role in the transmission of pain and sensory signals to the brain. TTX reduces the activity of sensitized nerve cells by selectively and reversibly blocking these sodium channels. Although sodium channels are complex structures, TTX selectively binds to the fourth domain on the outer pole of the channel. This blocks sodium ions from entering the nerve altogether, thereby interrupting or preventing nerve conduction. As a result, persistent and chronic pain may be relieved without the morphine-like side effects associated with existing pain management drugs. In persistent and chronic
TTX is approved by the FDA and Health Canada to commence pivotal phase 3 trials for chemotherapy-induced neuropathic pain, currently ongoing in North America and Europe. TTX has demonstrated clinical effectiveness on moderate to severe cancer-related pain in previous trials, currently on phase 2 trial, and could be desirable second-line pain treatment for moderate to severe cancer-related pain. Further indications include osteoarthritis, back pain, post-surgical pain, and diabetic neuropathy. A recently published randomized double-blind dose-finding study was undertaken to explore safety and trends in efficacy of 4 TTX doses and to identify the dose for further study. 125 patients with taxanes or platinum-related chemotherapy-induced neuropathic pain received subcutaneous injections in thigh or abdomen of placebo or TTX 7.5, 15, or 30 micrograms twice daily and 30 micrograms once daily for 4 consecutive days. Primary outcome measures was average patient-reported numeric pain scale rating scale score during day 21 to 28 post-treatment. Pre-plan and post-hoc analysis suggests an analgesic signal at tetrodotoxin 30 micrograms twice daily, dosed for 4 consecutive days, every 3 weeks. and safety data support a favorable risk-benefit profile in a population with limited therapeutic option. Changes in mean numeric pain rating scale score were not statistically different between cohorts due to small trial size and influence of a few robust placebo responders. Of note, all analyses were intended to be descriptive, and application of significant level of p-value less than 0.1 was intended to assist in the identification of the most promising dose regimen for further study. With that, the cumulative responders analysis showed significant difference from placebo with 30 micrograms BID cohort using the maximum response at any point with a p-value of 0.072, 5-day with a p-value of 0.059, 10-day with a p-value of 0.027, and 20-day with a p-value of 0.071 rolling averages. As mentioned, the p-value that was chosen was less than 0.1 in order to identify a dose regimen for further study. Most adverse events were mild to moderate, with oral paresthesia and oral hyperesthesia as most common. About 96% reported mild fingertip and pre-oral numbness and, as primary side effect. Side effects are short duration and not requiring medical attention. I thank you for your time and your attention. And with that, we can move to question and answer.
So for questions, if anyone wants to post questions online, then please do, or you can submit them by email. I think Lori Davis would be the best person to send those to. And to the extent that we have any time for questions and answers, we'll try to entertain them. Nima, I'd like to start out with a couple of questions. What is the route of administration for tetrodotoxin? Is it given orally? Is it given by injection, or some other type of application?
Great question. It is administered subcutaneously, either in thigh or abdomen, subcutaneously.
So it's designed to have systemic distribution, even though the chemotherapy-induced peripheral neuropathy is probably going to affect the hands, the toes predominantly first. My recollection is that it starts out with a bilateral distribution very similar to painful diabetic peripheral neuropathy. Is that correct?
That's correct. The specific study was done and evaluated different subtypes of sodium channels, and the specific sodium channel 1.7 is in the periphery, and the tetrodotoxin specifically targets sodium channel 1.7, which is in the peripheral nerves.
Okay, thank you. I know that in the past, and perhaps again in the future, we've talked about other small molecule inhibitors of NaV 1.7. Tetrodotoxin is a little bit different because it is a naturally obtained, naturally designed compound from the pufferfish. I don't know how many pufferfish it takes to be able to get enough medication, or whether it's produced synthetically, but sometimes natural products have some advantages over synthetic compounds. So it'll be interesting to see how this moves forward.
Absolutely, and of note, the use of certain bacteria in these animals have been led to the production of the tetrodotoxin. So one of the studies would be to look into how to use those bacteria to maybe produce it in a controlled environment.
Very good. All right. If there are no other questions, Nima, I'd like to thank you really for a very nicely put together presentation. And we'll then move on to the next presentation.
Thank you.
And for the next presentation, Dr. Samir Jani is going to be talking about disease-modifying products for osteoarthritis or rheumatoid arthritis. Dr. Jani is a professor of anesthesiology and pain medicine at the Garden State Medical Center in Whiting, New Jersey. Dr. Jani?
Good evening. Thank you for everyone for coming on the call and joining us. Excuse me. So I actually had a couple of options between choosing disease-modifying rheumatologic agents for rheumatoid arthritis versus osteoarthritis. And I ended up going with the osteoarthritis, and I felt that that was more critical to highlight because we already have some drugs out there that are disease modifying for rheumatoid arthritis. But really in the realm of osteoarthritis, we don't have too much. So I found that quite interesting. So next slide. So the compound is called spirometrin. It's recombinant human fibroblast growth factor 18. It was developed by Merck, and it's currently in phase 2 clinical trials. Next slide. So the mechanism of action is that the compound belongs to the fibroblast growth factor family. There's 23 members in this family of genes, and specifically number 18 is a very potent agonist of some of these receptors that we know accelerate and promote the development of cartilage, as well as chondrogenesis, and critical in cartilage and growth repair. There was a couple of clinical trials done on animal models, looking at these compounds and seeing what it could do with surgically created defects in animal models. So I just wanted to highlight a couple of those preclinical trials, one of which was done by Sennett et al., looking at bovine knees. What they did was they actually took a core of 6 millimeters of cartilage from a bovine knee, and then within that core took another smaller 3 millimeter extract from the middle, and then filled that middle with either spirometrin or placebo. And after looking at it histologically, they were able to see greater adhesive strength from the spirometrin, as well as increased collagen growth. Another study was done by Moore et al., looking at meniscus injuries in rats. So again, they surgically created meniscus injuries in these rats, and then ended up providing them either the medication versus placebo. They were given biweekly injections for 3 weeks. And they did see a dose-dependent improvement in the cartilage defects given in the rats who were given the active drug. They also saw new cartilage formation on the articular surface. So some of that preclinical data went into why this specific growth factor was chosen over some of the other ones. Now, anyone who's taking care of pain patients knows that osteoarthritis is a huge problem. We know that it affects 7% of the global population, and that the osteoarthritis is the most common type of arthritis, and it affects approximately 32 million people in the United States. It is also a very expensive condition to treat, especially when you look at joint replacement. I actually view it as also a human toll. You know, many patients who have osteoarthritis in their knees not only suffer from the pain, but then they're unable to exercise, they're unable to maintain partially a healthy lifestyle, which then leads them to higher rates of obesity, higher rates of cardiac disease. So it's not just a knee. We got to remember that knee is connected to a person. And if that knee is preventing them from being functional, it's going to lead to additional problems. Next slide. So this is a quick overview of the pathophysiology of what happens during osteoarthritis. So as you see on the top, that is essentially a normal looking knee with smooth membranes along the joint, as well as relatively well-preserved cartilage and meniscus, as well as reasonable amounts of synovial fluid. When you have degradation of that cartilage, it unfortunately allows for the inflammatory process to kind of take over within the knee, causing these subchondral bone defects, fraying the meniscus, creating osteophytes, which get in the way, and then reduces the viscosity of the synovial fluid, making it less ideal to help lubricate the joint. Next slide. So looking at current osteoarthritis treatment, step one is always lifestyle modification. Certainly weight loss, trying to exercise more. That is certainly things I tell my patients off the bat, and certainly send them for physical therapy to help strengthen the muscles around the joint. The next step, if that's not working, is typically steroid injections, but many patients aren't good candidates for steroid injections, and we know that repeat steroid injections do cause some deterioration of the joint space. Newer developments such as viscosupplementation are useful to help lubricate the joint. And don't get me wrong, they have great data behind it and they're quite useful in clinical practice, but that doesn't really change the disease. It just sort of helps hide it or lubricate it. And then ultimately the final step has been knee replacement, but as reviewed previously, it's quite costly and it's not a walk in the park for any of the patients. Anyone who's had a loved one get a knee replacement knows it's months of recovery and lots of hard work and physical therapy afterwards. And again, there's no guarantees with a knee replacement as well. So the next slide, please. So the newer highlight is sort of this concept of regenerative medicine. Is there a way that we can get in and restore some of the tissue, fix some of the tissue that's inherent or native to that area to see better clinical outcomes? Next slide. So this was the main study looking at the spurfurmin. It was published in JAMA several years ago. And it was looking at the thickness of the cartilage in several patients who were given different amounts of the drug at set intervals. Next slide. So it was a 5-year multicenter randomized trial. There was a total of 549 participants who were randomized into treatment arms. They were randomized into the 5 groups, 1, 1, 1. So it was an equal amount in each. And the patients were selected based off their radiographic evidence of osteoarthritis. So it wasn't mild. So they were judged on this criteria. So it goes from 0 to 4. So they chose patients who had a moderate amount of disease, but not too severe. And so the 5 groups received intra-articular injections, which were done under ultrasound guidance to ensure that they were adequately placed into the joint space of the different combinations that you see there. 100 micrograms Q6 months, 100 micrograms Q12, and then 30, and that's supposed to be 30 as well, not 3. And then finally a placebo group. Each treatment consisted of weekly injections over 3 weeks, and a total of 474 patients completed a 2-year follow-up. Next slide. So again, the primary endpoint was to see if they could restore height of the cartilage from baseline and at 2 years. And so they did a series of magnetic MRIs, not only at baseline, but then periodically through the 2-year follow-up, Q6 months, 12 months. And after 2 years, both groups that were receiving the higher dose of the medication had statistically improved cartilage thickness. So both of the groups that received it every 6 months as well as 12 months. There was no statistical difference between the groups that were given the 30 microgram dosing. And then at the 3-year follow-up, they did note that the patients retained that thickness improvement in their cartilage with that group that was treated every 6 months. So while looking at the MRIs, we could see that the cartilage was growing or repairing itself, which you would think would help improve functional ability. Unfortunately, the patients were also administered the WOMAC, which is a 24-point questionnaire. It stands for the Western Ontario and McMaster University Arthritis Index. And these 24 items look at several realms, one of which is pain with sitting, walking, laying down, 5 metrics there. Stiffness, first thing in the morning and then late at night. And then finally, the biggest group is functionality. Were you able to walk further, stand longer, get in and out of the car easier, shop easier, live your life easier after being given this drug? And unfortunately, there was no difference seen in this scale between any of the groups. So while they could see radiographic improvement of the cartilage, the question, and I guess the answer is that it didn't necessarily lead to functional improvement. There's some concern that the placebo arm may have jeopardized some of those results, that the injection of intra-articular saline may have contributed to not finding a difference between the groups. But at this point, there's been no further studies. Next slide. So
okay,
thank
so
you
let's
for
jump
paying
back
attention.
one slide. Just so that we can end on that one. Thank you, Dr. Johnny. That was really an interesting discussion. Although when we got to the end, we heard that the WOMAC didn't show that there was a statistically significant change in pain and stiffness or in physical function. one of the things that I do when I design osteoarthritis clinical trials is to also ask a patient global impression of change. In other words, how well do they like the treatment? Was that reported out in any of the literature that you reviewed, or is that something that we perhaps need to pay attention to in future studies? And the reason I ask is this, because this is a new medication, it's working by a different mechanism of action. We're applying the WOMAC, which was designed more than 20, 30 years ago for predominantly NSAIDs that were the vogue at the time, or later on COX-2 inhibitors. Is this the right tool to be able to measure the efficacy of a compound that is working in regenerative medicine, which is very different than a typical NSAID or COX-2 inhibitor? So that's why I like to use patient global impression of change, because it's agnostic in terms of whether the patient has specific measurements that are going to change, but it asks them in a global sense, how do you feel? Is this an improvement over where you were at baseline?
Sure, and that's a very interesting point. You know, in my clinical practice, we're not, you know, sitting down and administering these scales. We basically ask the patient, you know, how'd you do, and were you being able to do more? And sometimes that's what really matters, right? I appreciate your viewpoint, and you make a very valid point. The other issue that the authors highlighted, they also wondered, well, maybe we didn't follow the patients long enough, and would we have seen some further differences if we had waited a little bit longer? They didn't look at also, did one group proceed to knee replacement versus the other, you know? And I think that's more or less the real clinical piece that we're trying to improve. Yes, it's great if you see improvement on these functionality scales, but did we stop someone from getting a knee replacement? You know, I think that's a much more important tool to be looking at.
And also, did they list any medications that patients took at the same time that they were receiving this growth factor treatment? Does this exist, for instance, alongside of NSAIDs or COX-2 inhibitors or other drugs that we would use to control pain in these patients?
Well, from my understanding, they were allowed to continue with their usual treatments, but I don't recall if they excluded anyone from that.
Okay. In part, the reason that I asked that question is that there is some literature evidence that NSAIDs can inhibit wound healing or bone healing in particular. And whether that is true for cartilage healing under these conditions, I don't know, but maybe they have some preclinical data to take a look at that. I always like to think about any new compound, particularly regenerative compounds, need to exist within the context of standard of care that patients are receiving beforehand. So I try not to change standard of care, and I add on a new therapy to see if it would be effective that way. So I'm kind of wondering whether they designed their trials that way to allow standard of care to go on.
Sure. I mean, that's a great point too. I mean, we know that these, especially with some of the regenerative medicines, you really, you know, regenerative medicine techniques like PRP and that kind of stuff, you're not going to want patients to be on NSAIDs to see that clinical benefit. So certainly that there could have been some interference there.
Okay. Well, thank you very much, Dr. John.
Thank you.
That was an encouraging new type of treatment, a regenerative treatment for osteoarthritis. It'll be interesting to see how that progresses, whether it progresses, and whether this can be made into an effective treatment. It'd be nice to have an alternative to total joint replacement.
Yeah, absolutely. I mean, most patients aren't looking for a knee replacement.
And some are not going to be candidates either for a variety of reasons.
Absolutely.
So having an alternative would be good. All right, thank you very much.
Thank you.
And our third speaker before the next break is Dr. Tiffany Lin, who is an instructor in anesthesiology at Weill Cornell Medical College in New York City. And Tiffany's going to be talking about a rare disease called epidermolysis bullosa, which is something that we really have not talked about in pain medicine very much for the last many years, up until maybe 5 years ago when I heard about new treatments for the first time. And it's interesting that Tiffany has two different treatments that she's going to introduce us to today that currently are in clinical trial. Tiffany?
Right, thank you. I'm Tiffany Lin. I'm one of the faculties in anesthesiology and pain management at Weill Cornell. Like Dr. Smith mentioned, I'm going to talk about a very rare disease called epidermolysis bullosa. And just because it's probably not commonly seen by us, I'm just going to spend a little bit more time talking about it. Next slide. So what is epidermolysis bullosa? It is a group of rare and genetically inherited disorders characterized by mucocutaneous fragility and bullosa formation from minimal trauma. It is very rare, affecting about 20 per a million live births, and there is no difference in sex or ethnic groups. Next slide. So far, there are about 30 subtypes recognized with pathogenic mutations in 16 distinct genes identified. And these genes encode proteins influencing cellular integrity and adhesion. The 30 subtypes can be grouped into 4 major types based on the plane of cleaving within the skin. So EB simplex is the most common and is characterized by dysfunction in the epidermis. Junctional EB is characterized by blistering within the lamina lucida of the basement membrane zone, which is at the junction between the dermis and epidermis. Dystrophic EB is characterized by fragility below the lamina densa of the basement membrane zone. And lastly, Kindler EB is characterized by variable level of ultrastructural splits within the basement membrane zone. Next slide. So in terms of the clinical presentation, EB has very broad phenotypic spectrum, both between and within the subtypes, with wide extent of cutaneous disease and extracutaneous complications. In the severe diseases, the epithelial-lined organs are also affected, so that can lead to multi-system involvement, scarring, leading to aggressive cutaneous malignancy, significant morbidity, and early mortality. Next slide. So in terms of cutaneous disease, as you can see, it can be quite debilitating. I want to point your attention to panel E, which shows a typical pseudosyndactyly, which is also called mitten deformity. And that's only seen in severe recessive dystrophic EB, which I'll talk about that more later. And panel F shows squamous cell carcinoma that arises in the chronic wound. Next slide. Extracutaneous manifestations. As you can see from the slide, EB is not just a cutaneous disease. It affects almost every single organism, and it can be very debilitating or fatal. Next slide. So now I'm going to talk about more specifically recessive dystrophic epidermolysis bullosa, which is what our novel agents are targeting for. As a severe form of dystrophic EB, it is even more rare. There are only about 3,200 cases in the US, and it impacts about 3 births per million live births, but it has the highest rate of morbidity and mortality. Next slide. So in terms of the pathophysiology, it is an autosomal recessive disorder. It is characterized by gene mutation in COL7A1, which encodes for a type 7 collagen. So type 7 collagen is a large triple helical protein that's found beneath the lamina densa and is a major component of the anchoring fibrils. So the anchoring fibrils, they are vital in promoting the cohesion between the dermis and epidermis and the upper dermis. So without these fibrils, the keratinocyte adhesion is disrupted, which causes severe blistering and open wounds in response to any friction or trauma. And because of the deep level of separation in the dermis, the recurrent inflammation, scarring, and fibrosis can lead to the formation of contractures and pseudosyndactyly that I showed you earlier, which causes increased severity and also diminishes the quality of life of patients. Next slide. So as I talked about, severe recessive dystrophic EB has marked cutaneous and extracutaneous manifestations. Most significantly is the development of squamous cell carcinoma, which is a leading cause of death in this population. The risk of development of squamous cell carcinoma increases with severity and chronicity of wound healing. It is also very aggressive with high risk of early death due to metastasis. In terms of musculoskeletal, as you can see in the second image, the recurrent blistering and scarring could eventually lead to hand deformities where all the fingers and thumb are bound in scar tissue. And this is inevitable despite preventive measures and may require surgical release with skin grafting. And as you can imagine, this disorder can cause very debilitating pain and pruritus, which is very disabling and is identified as the most important areas for therapy development, secondary only to wound care. Next slide. And aside from the clinical burden itself, recessive dystrophic EB also has considerable economic and humanistic burden for the patients and their families due to the high cost of wound care, medications, and hospital stays. And large proportions of patients also experience anxiety and depression, which leads to the inability to maintain physical or emotional relationships with their loved ones. Next slide. So currently there is no curative treatment to resolve the disease or manifestations. The management is mostly focused on multidisciplinary care for symptom relief or prevention of complications. However, in recent years, efforts have been turned towards translational therapies, which include cellular therapy, gene therapy, and protein replacement therapy to correct the underlying molecular pathology. So today I'm going to talk about two novel therapies, FCX007 and EB101. And sorry, there's a mistake in the slide. They are both cellular and gene therapies. Next slide. So FCX007 is a cellular therapy where dermal fibroblast cells are collected from the patient, and they are genetically modified with the viral vector containing the CLL7A1 gene to produce the healthy copies of the type 7 collagen. The modified cells are then injected back into the patient's wounds intradermally, where the functioning type 7 collagen can then help form the anchoring fibrils in the skin. And it is advantageous, and that is a local administration, so avoids any systemic treatment and potential side effects. It also avoids immune reaction by using the patient's own fibroblasts. So currently this therapy is enrolling for a phase 3 clinical trial. Next slide. So this is results from their phase 1/2 clinical trial. It is done by Stanford University on 6 patients with severe recessive dystrophic EB. And their primary endpoint is safety. And this results show that this therapy is well tolerated up to 52 weeks after administration. There have been no serious adverse events reported, no replication competent virus was detected, and no significant autoantibody response was detected as well. In terms of efficacy at 52 weeks, you can see in table 2 and table 3, 67% of treated wounds show significant wound healing, and that's defined by more than 75% healing compared to 16% of untreated wounds. At a molecular level, they also showed that there was type 7 collagen expression at the dermal epidermal junction, and also restoration of anchoring fibrils at 3 months. Next slide. So next therapy that I'm going to talk about is called EB101. So similarly to the previous therapy, the keratinocytes were isolated from the patients. Then the type 7 collagen gene was introduced into the cells with a retrovirus. The gene-corrected cells then were grown into a larger epidermal sheet that is then transplanted back to the patient's wounds, providing cells with the ability to grow and develop normal skin. So that is also currently enrolling for a phase 3 clinical trial. Next slide. So this is the result of their phase 1/2A clinical trial, and it was a single center randomized clinical trial done at Stanford University as well, assessing EB101 for wound healing in patients with recessive dystrophic EB. So the study had 7 adults with 42 sites total, and it was followed by 2 to 5 years. And they evaluated the long-term efficacy, safety, and patient-reported outcomes. So in terms of safety, the results show that the therapy was safe with no serious adverse events reported. And in terms of efficacy, at 6 months, 95% of the treated wounds had significant wound healing versus 0% of the untreated wounds. And this effect persisted until 2 years, where 71% of treated wounds had significant wound healing versus 17% of untreated wounds. And also the treated wounds with significant healing also demonstrated patient-reported improvement in pain, itching, and wound durability. Similarly, at the molecular level, they also showed C7, which is the type 7 collagen expression that persisted up to 2 years after treatment in 2 of the 7 participants. So all in all, the advances in gene and cellular therapies are promising and paving the way for clinical success in this debilitating disorder. And we look forward to seeing the phase 3 result to see if it can make any difference in this patient population. Next slide.
All right, thank you very much, Dr. Lin. This is really encouraging to hear that there's a new treatment on the horizon for something that's a devastating disorder. I'm wondering, first off, is the EB lesions more on the distal limbs or in areas that receive high flexion, such as in joint areas or in areas that have more abrasion? And is it limited just to certain areas on the body for an individual patient, or can it be anywhere on the body?
So it can be anywhere that is susceptible to friction and trauma. So most often is in the limbs and hands, feet. It can also affect mucosal tissues such as the eyes, oral mucosal surfaces, esophageal mucosal surfaces.
And how are these test compounds given? You said that they're administered locally. Is this by injection into the tissue?
Yeah, so
Injection?
the first one, the FCX007 is injected intradermally into the wounds themselves, whereas the other one is they actually grow a sheet of the genetically modified cells and they transplant them onto the wounds.
Okay. So it'll be interesting to see whether maybe both of these treatments would succeed in the future.
Yeah.
I noted that they are using autologous cells initially, so they're avoiding any sort of immune response. Is that true in terms of patients not having any immune response during the phase 2 and phase 3 clinical trials?
Yeah, they actually looked for any autoantibodies and didn't see any. So there was no immune response to the treatment.
Great. And I'm curious, did they do a patient global impression of change? Did patients report that they appreciated the treatment better in the treated group than in the placebo groups?
So in the EB101 study, they did demonstrate improvement in pain score, pruritus. So there was quality of life improvement. Great.
Maybe long-term, maybe we'll see some decrease in the rate of cancers that these patients develop in those same lesion areas.
Yeah, definitely. If the treatment is helping the skin with its durability, then without the shearing and the scarring, then the risk of cancer should go down.
Great. I'd like to ask Dr. Witkin if she has any questions as well, since we still have 2 or 3 minutes left. Lisa, would you like to ask?
Oh, I'm sorry. I didn't have any specific questions about this presentation, but it's been very interesting.
All right. Well, Dr. Lin, I'd like to thank you. I'd like to thank, again, Dr. Johnny and Dr. Yas Panada for really encouraging presentations on exciting new products that are currently in development. I think that every one of these look very different than drugs that we typically think of as being analgesic drugs, but that means that there's been an enormous progression in development of new theories, new types of treatments, and potentially new tools that pain physicians can use in the future. So I really appreciate each of you for your presentations today.
Thank you.
So thank you to all of the speakers for those excellent presentations. We hope everyone is enjoying these sessions. Before continuing with the next session of the Innovations in Research program, please join us for a message from our sponsor.
Hi, everybody. My name is Jessica Feltman. Thank you so much for letting me participate in the program tonight. I am representing Botox and Allergan. And a few months ago, you heard from my partner, Michael Barnhard, on chronic migraine and the FDA approval for Botox and the paradigm associated with the chronic migraine injection. Today, I'd like to introduce more in-depth knowledge surrounding cervical dystonia. As you can see here, we're going to be using this workbook, which if you want a copy, everybody at the EPA knows how to get in touch with me no matter where you are. I can get in touch with your rep and send you one. So I know what you're thinking, that spasmodic torticollis is really something seen within movement disorders, but I hope by the end of my presentation tonight, you realize that the mild spasmodic torticollis patient is actually quite common in your pain departments. And Botox is FDA approved as first-line therapy for spasmodic torticollis. In fact, Botox is well known for the chronic migraine indication as well as, of course, cosmetic. But Botox has been FDA approved for spasmodic torticollis since 2000. And it actually had its first FDA approval for blepharospasm in 1989. So we're talking about being on the market for over 30 years. So with that, some of the common postures involved in cervical dystonia are seen on the top here: torticollis, lateral collis, anterocollis, and retrocollis. And I can imagine you all saying to yourself right now that you don't see that. You don't see those postures in your practice. Those patients are going to movement disorders. Why is she talking to us about that? But what I challenge you to do by the end of the evening is just think about some of the subtle features of cervical dystonia and think about some of the patients you've seen in the past couple of weeks, if not today. So it is very typical of a spasmodic torticollis patient to have generating neck pain, lack of range of motion, shoulder elevation, chin jutting out from their chest for over 5 years. It normally takes 5 years for a cervical dystonia patient to get diagnosed. And in fact, it takes another year, year and a half till they actually get treated with Botox. So as you can see on the right, 89% of patients report neck pain. So I know what you're all thinking, and the answer is yes. All your patients have to present with is neck pain in order to be considered spasmodic torticollis. Remember, there is no blood test for this disease. It's just a diagnosis of differentiation. So again, 89% of patients report neck pain and 60% can report tremor. Now, your patients do not have to have tremor. It just is a subtle feature associated with dystonia. So some symptoms beyond neck pain and tremor that you can consider are sensory tricks, such as a patient who might need to lean against a wall while they're eating a meal, a patient who has morning benefit. They feel good in the morning. They feel less pain. When you touch them or you palpate these patients, are they feeling tenderness, and does it hurt? And how are they? Does their symptoms get better or worse when they're fatigued or have stress, when they're walking or driving or even writing? So neck pain and head tremor are definitely two features I'd love for you to start looking for. And you can use these screening techniques to help identify more easily the cervical dystonia patient. And all of your Botox reps have access to other materials that also can help screen for spasmodic torticollis. So first, what you want to do is have the patient just sit in a chair in the middle of the room, no back, not leaning against anything, and ask the patient if they've been experiencing neck pain or they're using these sensory tricks that we spoke of. Sometimes it's talking, sometimes it's chewing gum, anything that they can concentrate on that helps them keep their head up. Then what you want to do is distinguish between cervical dystonia tremor and other tremors such as essential tremor and Parkinson's disease. This is pretty straightforward, as cervical dystonia tremor is more painful and it's inconsistent, where essential tremor or tremor associated with Parkinson's disease, this is not as painful and it's very predictable. The patients are suffering with this tremor consistently, but it really doesn't bother them or hurt them until maybe they try to balance a coffee cup and they realize the coffee is spilling out. But the tremor associated with dystonia is more painful. So what I ask you then to do is have the patient, who's now sitting in the chair in the middle of the room, instruct the patient to move his or her arms up and down in a repetitive and alternating pattern. And then just observe the full expression of this movement and what happens to that patient's posture. Does the patient's head turn a little bit? Does it tilt a little bit? Do you notice that they start shaking a little bit? Do their arms start shaking? Whereas when their hands were in their lap, there was no movement. You want to have the patient close their eyes too, because when they're not looking at something and concentrating at something, you might see a little deviation in their shoulder elevation or their chin position or the posture of their neck. You can observe the patient's head position while they're walking. And then of course, consult the Twister scale, which is on the next page. So the Twister scale, or the Toronto Western Spasmodic Torticollis Rating Scale, this is just a screening guide for you. This is not necessarily something that you need for insurance purposes. Botox is FDA approved as first-line therapy for spasmodic torticollis and 100% covered on Medicare, which means the private insurances will follow suit. So this is covered. There is no step therapy. You can go right to Botox first, but you need to know what you're looking for and how to document. So if you can read these first 5 questions, does your patient find his or her head turning, tilting, or shifting in any direction? Does your patient's head shake or jerk? Do your patient's shoulders lift or pull up or down without his or her control? Have other people told you that your patient has head tremor? And does your patient have any pain or stiffness in his or her neck most of the time? If your patients answer yes to any one of these questions, this could be a potential spasmodic torticollis patient. It does not have to be all 5 of these questions as a yes. It can just be one. And then as you can see, it's asking if your patients are using sensory tricks, how debilitating is the pain? What was the etiology of the uncommon posture? So again, this is just a tool that you can use in your office to rule spasmodic torticollis in or out. Very briefly, the treatment framework: you're going to have these patients, you're going to diagnose them, and what you're going to do is come up with a common and established goal that you and the patient and the caregiver all agree on. What you're going to do is you're going to write that goal down in the patient's chart, and you're going to remind the patient when they come back that that was, what they wanted to do. Because what you might find is that the patient has less pain with the first injection, maybe even the first 2, and not necessarily a change in their posture. So what you want to do at their 4 or their 6-week follow-up is you want to just assess the patient and see if maybe the next time you need to add more muscles or more dosing. And of course, your Botox rep can walk you through all of the postures, the dosing, and the muscle selection. So essentially, this Botox patient is going to come back every 3 months. this is part of the right plan. They're going to get injected 4 times a year. They're going to have 2 follow-ups. And then if your office has physical therapy, you're going to get them into your physical therapy. You're also going to be using EMG guidance for this procedure. So I'm just going to walk you through 2 very common postures that we see very commonly in pain practices. First is this posture of torticollis, which is the chin over the shoulder. The reason I want to bring this to your attention is that contralateral muscles are involved. So if the chin is over the right shoulder, what this workbook will show you is both the ipsilateral and the contralateral muscles involved. The patient might grab their ipsilateral side and tell you that's where they feel pain, but you need to follow the posture and not necessarily the pain, because what you're working with is agonist versus antagonist muscles, and you're going to want to inject the agonist muscle, because perhaps by weakening that muscle, you're going to relieve the ipsilateral side that's working too hard. So again, this is all something, and on June 1st, we're going to come back with the EPA and talk to you about training opportunities for Botox. But this whole concept of agonist versus antagonist is very important in the pain practices. And then another common posture is on the right here, this sagittal shift. So this is a clinical presentation of cervical dystonia that's common, where perhaps a patient has just been sitting at a computer for over a year and their chin isn't necessarily flexed down like your anterocollis patient would be, but it's just the chin extended out. And this very simply would be a bilateral injection of the sternocleidomastoid. So there are 6 postures. There's sagittal shift and lateral shift. There's retrocollis, which is the head extended back, and anterocollis, or the head flexed forward. And then lateral collis, which is leaning to one side and is all ipsilateral. And then this torticollis, as we discussed earlier. So I'm not going to get too much into the anatomy tonight. My main goal, if you took nothing else away from this presentation, is to be looking for those subtle features of neck pain and perhaps neck head tremor, and using some of these screening techniques to help identify your cervical dystonia patients in your office. Use the Twister scale, and then please get my phone number from anybody at the EPA, and we can put you in touch with your local Botox representative. So I look forward to speaking with you all on June 1st about all of our training opportunities that we have virtually, live, with expert injectors, with anatomists, and of course we have electronic models that we can bring in that you can also practice injecting, and the muscle will light up so you'll know exactly where you are. So I appreciate your time, and I hope to hear from you all. Thank you.
Welcome back, and thank you again to our sponsors. We will now begin with the second half of the Innovations in Research program, and I will turn it back to our moderators, Dr. Schmidt and Drs. Interisi. Again, the CME information there for your reference.
Okay. I believe that I'm going to be the main moderator for this session. Is that correct, Bill?
Yes, that's correct.
So the first speaker is Dr. Baruch Kim, who's going to talk about NDAs that have been submitted, and the one he's going to talk about is TALTs. So go ahead.
Thank you for joining us. My name is Baruch Kim. I was initially supposed to present 2 drugs, Excusmab and Triptan, Zomitriptan. However, given the limited time, I'll be presenting only one new drug, Excuseme, since Tripta is a reformulation of an older drug without the FDA approval yet. Next slide, please. So Excuseme is an injectable medication for the treatment of autoimmune diseases. It's an immunized monoclonal antibody, interleukin 17A antagonist. Excuseme is approved to treat adults and children 6 years and older with moderate to severe plaque psoriasis who may benefit from systemic therapy, such as taking injections or pills or treatment using UV light, such as phototherapy. Adults with active psoriatic arthritis, adults with active ankylosing spondylitis, and adults with active non-radiographic axial spondyloarthritis with objective signs of inflammation. Next slide, please. So to talk a little bit about the history of Excuseme, it received its FDA approval for the treatment of pediatric patients with moderate to severe plaque psoriasis in 2016. In 2019, Excuseme received FDA approval for the treatment of active ankylosing spondylitis, also known as a radiographic axial spondyloarthritis. In 2020, it received FDA approval for the treatment of non-radiographic axial spondyloarthritis. The term axial spondyloarthritis refers to a chronic inflammatory disease of the axial skeleton, and it's a prototype ankylosing spondylitis, also known as radiographic axial spondyloarthritis. It's mandatorily defined by evident radiographic structural damage in the sacroiliac joints, which becomes visible years after symptom onset. To encompass earlier stages, the term non-radiographic axial spondyloarthritis was introduced to include patients with suggestive clinical features of axial spondyloarthritis, but no radiographic sacroiliitis. Non-radiographic axial spondyloarthritis may be defined by clinical features and MRI detected inflammatory lesions in the SI joints, or the presence of HLA-B12, HLA-B27 positivity and the absence of MRI findings. Next slide, please. Let's talk a little bit about the mechanism of action. Excuseme binds to interleukin 17A and inhibits the interaction between the interleukin 17A and its receptor 17RA. And there's the hyperproliferation of keratinocytes that is driven by cytokines from T cells, and then the keratinocytes amplify the inflammatory response, leading to psoriatic plaque, leading to infiltration of activated T cells. And circulating T helper 17, 22, and T helper 1 cells are found to be elevated in patients with psoriasis. And the activated T cells produce other cytokines, interleukin 17A and F, act on fibroblast, and leading to high elevation of interleukin 17A and F, leading to further hyperproliferation of keratinocytes. Next slide, please. Excuseme selectively binds with the interleukin 17A cytokine, inhibits its interaction with the interleukin 17 receptor. Interleukin 17A is a naturally occurring cytokine that is involved in the normal inflammatory and immune responses. Excuseme inhibits the release of pro-inflammatory cytokines and chemokines that cause inflammation, matrix destruction, and cell migration. Next slide, please. So in 3 randomized placebo-controlled clinical trials with a total of 3,866 patients with plaque psoriasis, it's found to achieve a greater clinical response than placebo as assessed by psoriasis area severity index score and static physician's global assessment. It also affects the immune system, leading to increasing the risks of contracting infections. So the medication guide provided serious hypersensitive responses, exacerbation of inflammatory bowel disease, and common side effects include upper respiratory infections, injection site reactions, nausea, and fungal infection. In all 3 studies at 12 weeks, 87 to 90% of patients treated with Excuseme also a significant improvement of their psoriasis plaques. Next slide, please. So So there are warnings and precautions, starting with the infection. Excusement is a medicine that affects your immune system. It may lower your ability of your immune system to fight infections and may increase your risk of infection, which could become, which could sometimes become serious. Most common reactions associated with the treatment are injection site reactions, upper respiratory tract infections, nausea, tinea infection. And patients should be evaluated for TB, tuberculosis infection prior to initiating treatment with excusement. We should be administering to patients with active TB infection, and before initiation of before administering the medication, and the treatment of latent TB should be initiated. And patients should be closely monitored for the patient should be closely monitored for signs and symptoms of active TB during and after treatment. And hypersensitivity and serious hypersensitive reactions such as angioedema or urticaria occurred in the excusement group in clinical trials. Anaphylaxis, including cases leading to hospitalization, has been reported in post-marketing use with the medication. And then it's found to be associated with exacerbation of inflammatory bowel disease. Patients treated with excusement may be at an increased risk of inflammatory bowel disease. Clinical trials, Crohn's disease and ulcerative colitis, including exacerbation, occurred at a greater frequency in the medication group than the placebo. During the treatment, the patient should be monitored for onset or exacerbation of inflammatory bowel disease. And if inflammatory bowel disease occurs, the medication should be discontinued, and appropriate medical treatment should be initiated. Immunizations prior to initiating therapy with excusement consider completion of all age-appropriate immunizations, including, according to current immunization guidelines, and we should avoid the use of live vaccines in patients treated with TALS. However, our National Psoriasis Foundation, however, recommends receiving COVID-19 vaccination regardless of the medications. Next line. This diagram demonstrates psoriatic arthritis efficacy in patients with joint symptom in both biologic naive and tumor necrosis factor inhibitor experienced patients. The ACR20 is a measure defined as both improvement of 20% in the number of tender and number of swollen joints, and a 20% improvement in 3 of the following criteria, including patient global assessment, physician global assessment, functional ability measure, visual analog pain scale, and ESR and CRP. These were phase 3 randomized double-blind placebo-controlled trials to evaluate the efficacy and safety of the medication compared with placebo in patients with active psoriatic arthritis. Patients in SPIRIT P1 were biologic naive, and P2 were tumor necrosis factor inhibitor experienced, having had an inadequate response and or intolerance to 1 or 2 prior TNF inhibitors. In both trials, the primary efficacy endpoint was the proportion of patients achieving ACR20 response at week 24. All patients were older than 18 years of age and had greater or equal to 3 swollen and 3 tender joints. Patients were randomized to placebo or excusement 80 milligram every 2 or 4 weeks following 160 milligram starting dose. And as you can see on the screen, the percentage of the patients achieving response rate and P1 and P2 are elevated in comparison to the placebo at 58% and 53%, ACR 50, 40%, 35, and 23, 22. Next slide, please. This graph demonstrates ASA's 40 response rate at week 16. Course V and course W were phase 3 multicenter randomized double-blind clinical trials designed to evaluate the efficacy and safety of the medication compared with placebo in patients with active ankylosing spondylitis. The ASA 40 response was defined as a greater than 40% improvement and an absolute improvement from baseline in 3 of the following 4 domains, including back pain, patient global assessment of disease activity, physical function, and inflammation without any worsening in the remaining domain. The primary efficacy endpoint for both trials was proportion of patients achieving ASA 40 response at week 16. All patients were greater than 18 years of age, had a baseline BETH ankylosing spondylitis disease activity index score greater than 4, and established diagnosis of radiographic axial spondyloarthritis with sacroiliitis. The patients had at least one spondyloarthritis feature per ASA criteria, and they were randomized to placebo or Exidumab 80 milligram or 160 milligram at week 0, followed by 80 milligram every 2 or 4 weeks. And all patients experienced back pain for at least 3 months with onset before the age of 45. And as you can see on the screen, the percentage of the patients achieving response rate for ASA S40 was found to be 48% in comparison to the other drug, adalimumab, 36% and 18% the placebo. Next slide, please. So once again, this kind of similar to the graph shown earlier. This is the ASAS 40 response rate through week 52. The efficacy or the patient's achieving response rate remain elevated at week 52. So, and then the percentage of the other group was not compared. Next slide. Patient global assessment and BAS-FI scores at week 16. As Beth ankylosing spondylitis functional index is a measure using a visual analog scale questionnaire focused on the patient's ability to perform specific functional tasks. And then patient's global assessment score was looked into as well. It's the other way around. The PAS-FI, the higher the number, the better it is. Then patient's global assessment score, the lower the number, the higher, the more efficacious medication. Next slide, please. Yes, and then they looked at the improvement in morning stiffness and also spinal pain at week 16. Morning stiffness, the percent improvement of morning stiffness was elevated 45%, and then the spinal pain improvement of the spinal pain was also elevated or improved at 42% in comparison to the other medication, adalimumab, 39%, 37%, and then the placebo group, morning stiffness 19%, spinal pain 24%. Next slide, please. Next slide. COS-W, tumor necrosis factor inhibitor experienced patients. They looked at both ASAS 40 and ASAS 20 as 25%, 48% as opposed to 13%, 30% in the placebo group. Next slide. Next slide, please. So to kind of wrap up the presentation, Exidumab is an injectable medication used to treat people 6 years of age older and older with moderate to severe plaque psoriasis who may benefit from taking injection pills, also known as systemic therapy, or treatment using UV light or phototherapy for those with active psoriatic arthritis, active ankylosing spondylitis, active non-radiographic axial spondyloarthritis with objective signs of inflammation. However, it is not known if Exidumab is safe and effective in children for conditions other than plaque psoriasis or in children under 6 years of age. Exidumab affects the immune system and may increase your risk of infections. TB should be checked before starting the medication, and the patient should be monitored closely for signs of tuberculosis during and after treatment of with medications, and Crohn's disease and ulcerative colitis, inflammatory bowel disease can start, or it could get worse with the medication use. And I think it's quite useful to get to know a little bit about some of these newer agents that are continuing to be developed for the treatment of psoriatic arthritis and spondyloarthritis. Thank you.
Okay, we have time for 1 or 2 questions. Anyone? Dr. Kim, can we go back 1 slide?
Yes.
Oh, yeah, this one. Okay. So these are pretty can you go over these response rates again?
Yes. So
So what is the ASA S40 versus S20?
so ASA40 response is defined as of greater than 40% improvement and absolute improvement from the baseline.
Okay. Okay.
In back pain, functional status, and inflammation.
So there is a kind of dose response there.
Yeah.
Okay, good. I didn't quite understand that. Are there any other questions or comments? Thank you, Dr. Kim, for a very nice presentation. And I think we can move on to the next one. And this one is going to be about novel opioids. Yeah, here we are. And Dr. Kalua, excuse me for mispronouncing your name, and Dr. Earls. Go ahead, tell us about these novel opioids, please.
Hi, thank you. I'm Dr. Drawbacks from Johns Hopkins, and I'm happy to present to you all today with my fellow Dr. Brent Earls, who is actually signing on to faculty at the George Washington School of Medicine this upcoming July. So we're happy to speak to you, and I'm going to hand this over to Brent, and he will take it from here.
Oh, you're mute. Oh, okay, good.
Yeah, so thank you. Good evening. Thanks, Dr. Topical, for the great introduction. The drug that I'm going to discuss today is difelikefalin, or Korsuva, made by Cara Therapeutics. Next slide. So our objectives for this talk are to discuss the development status and mechanism of action, describe its role in acute pain and relevant phase 2 studies, and examine its role in pruritus and relevant phase 3 studies for that indication. Next slide. So where does difelikefalin fit into the landscape of pain management? Next slide. So current mainstay drugs used to treat acute and post-surgical pain are mu-opioid agonists, and these are often used in the context of a multimodal regimen. On the left of the screen, I provided some examples of commonly used mu-opioid agonists available in the US. Most of these drugs are very familiar, and we're aware that they are effective painkillers by mediating acute changes in neuronal excitability. Due to the widespread nature of mu-opioid receptors, these drugs can also be responsible for adverse central effects, including nausea, vomiting, itching, and most feared respiratory depression. Next slide. For the indication of acute and postoperative pain, Korsuva has completed phase 2 trials currently. We'll review this evidence later on in the talk. However, Cara Therapeutics has had a primary focus over the past 3 to 4 years in its pursuit of pruritus as an indication for this drug. Next slide. So the indication that's currently being pursued is in the treatment of uremic pruritus. In localized disease, topical medicines like capsaicin, topical steroids are frequently used. However, in uremic pruritus, itching is more often diffuse in nature, which often necessitates systemic therapy. Oral antihistamines are commonly used because they're easily accessible and relatively inexpensive. More recently, antineuropathic drugs like gabapentin have been explored as possible options as well. These systemic therapies also cross the blood-brain barrier and often have untoward side effects, including nausea, dry mouth, and more importantly, somnolence. Next slide. So currently, difelikefalin is pursuing multiple approvals for indication and route of administration in the field of itch. The company just recently submitted a new drug application for approval for IV administration in dialysis-dependent patients with uremic pruritus. But you can see oral administration and other indications is in the pipeline as well. Next slide. So now let's explore how this drug acts to treat pain and itch. Next slide. So Korsuva is a peripheral peptidic kappa opioid agonist. The opioid receptor system activates inhibitory G proteins, forming homo and heterodimer complexes, which signals downstream kinase cascades in order to scaffold a variety of proteins. However, we currently lack understanding related to the diversity of signaling of opioid receptors, such as kappa opioid receptors, and how exactly the secondary messengers act to modulate pain and behavioral activity. Kappa opioid receptors are implicated in the inflammatory cascade. Korsuva, as well as other kappa opioid agonists, reduce cell adhesion molecule expression, inhibit cell trafficking, alter mRNA expression, and reduce levels of substance P and CGRP in joint tissue. Furthermore, kappa opioid agonists reduce the expression of pro-inflammatory cytokines such as TNF alpha, IL-1 beta, IL-6, and IL-10. And Korsuva is very specific to the kappa opioid receptor and has limited penetration into the CNS, theoretically limiting side effects associated with traditional opioids. Next slide. So pruritus is thought to be mediated by several mechanisms, but most conclude it's mediated by pruritogens, which act by stimulating itch-specific C fibers. Opioid receptors have been implicated in the central and peripheral induction of itch and may be the result of an imbalance of mu opioid receptors and kappa opioid receptors in central and peripheral pathways. This is commonly demonstrated clinically where agonism of mu opioid receptors promote the transmission of itch signals, whereas agonism of kappa opioid receptors inhibit the transmission of itch signals. As you can see in the figure, kappa opioid receptors are present at multiple sites in the inflammatory cascade, which may explain their powerful inhibitory action. Next slide. So now let's evaluate the evidence in clinical trials for these indications separately. Next slide. Oh, thank you. So one of the first studies of Korsuva looking at its safety and efficacy in pain was a randomized double-blind placebo-controlled parallel group study performed by CUTANEOUS of women following laparoscopic hysterectomy. This four-arm study investigated the opioid-sparing effect of administration of a single IV dose of diphenhydramine at 0.04 milligrams per kilogram before and or after undergoing laparoscopic hysterectomy. So in the first arm, patients were given placebo before and after surgery. In the second arm, patients were given the study drug before and placebo after. In the third arm, placebo was given before surgery and study drug was given after surgery. And in the fourth arm, the study drug was given before and after surgery. Primary outcome measures were total morphine consumption in the first 24 hours, and secondary measures were total pain relief based on patient-reported Licart scale and patient-reported nausea and vomiting. Next slide. The figure on the left represents the use of morphine as rescue 2 to 24 hours after the second infusion in the placebo group versus the group that received Korsuva before and after surgery, which did show a statistically significant difference between these groups. The figure in the middle shows significant pain intensity improvement between all groups that received Korsuva compared to placebo only, with no significant difference between the blue bars, which represent groups that received at least one dose of Korsuva. And the last figure shows patients who received Korsuva following surgery were significantly less likely to require rescue medication within the first few hours after the infusion. Next slide. In another study for use in pain, THERAPEUTICS looked at drug likability as a proxy for abuse potential in a single center, randomized, double-blind, active and placebo-controlled four-way crossover study. In this study, current opioid users aged 18 to 55 years old were given one of 4 IV treatments, either placebo, Korsuva 5 micrograms per kilogram, Korsuva 15 micrograms per kilogram, or pentazocine 0.5 milligrams per kilogram, which is another kappa opioid agonist. Sequential treatments were separated by a 48-hour washout period. Primary endpoint was drug liking based on VAS score, where 0 was strong disliking, 50 was neither like nor dislike, and 100 was strong liking. Secondary data included treatment emergent adverse effects. So results showed within 5 minutes after receiving either low or high dose difelikefalin, the median drug liking VAS score were slightly higher relative to placebo, but returned to a similar value within 1 to 2 hours. The maximum drug liking VAS score following administration of pentazocine was significantly higher compared with each of the other 3 treatments. Treatment-related adverse effects were similar among the 3 groups, with most common symptoms reported being dizziness and headache, although nausea was significantly higher in the pentazocine group compared to both difelikefalin groups. Of note, the drug likability scale has been validated in mu opioid agonists, but it's not as widely utilized in the context of kappa opioid agonists. Next slide. So the last trial or trials that I wanted to include in the talk are the phase 3 trials called CALM-1 and CALM-2 respectively. CALM-1 was a double-blind and placebo-controlled study that randomly assigned 378 patients undergoing hemodialysis who had moderate to severe pruritus to receive either IV difelikefalin, 0.5 milligrams per kilo, or placebo 3 times per week following dialysis for up to 12 weeks. Primary outcome was percentage of patients who had a greater than 3-point improvement from baseline based on a weekly mean of daily worst itching intensity numeric rating scale. CALM-2 was similar in method, but expanded to include sites outside the US as well. So as you can see from the figures provided, the results did show significantly higher responder rate in the treatment group, which in later studies was durable over 15 months. Thank you for your attention, and I'll take any questions.
So I have a question. Of course, when we think about kappa agonists, we think about the spectrum of psychotomimetic effects. And where is this drug on that spectrum in the doses that you're using here?
Right. So difelikefalin's been designed to be more peripherally acting. Its focus is outside the CNS, so it has a tough time penetrating within because of its molecular size and also its charge. So the psychomimetic effects centrally that you might see in even other kappa opioid agonists like pentazocine are very limited in the use of difelikefalin, even at the higher doses that were studied at 0.5 milligrams per kilo or 15 micrograms per kilo administration daily.
Okay, thank you. Thank you.
Yeah, no problem.
Any other questions? Okay, well, thank you very much for this very interesting data set. Thank you. Okay, the next presentation is going to be about sickle cell disease and Veloxator, and Peter Lascarides is going to give us that presentation. I see you there, Peter. You got your microphone on?
Yeah, I think I do.
Okay, go ahead. It's all yours.
All right. Good evening, everyone. Thanks for hanging in. I'm Peter Lascarides. Going to be talking about an exciting new medication used to treat sickle cell disease called Voxelotor. So let's see if the controls work here. Next slide, please. Excellent. There we go. So I have no disclosures. Next slide. A little bit of pertinent background. We'll go over the pharmacology, clinical studies, outcomes, and clinical use of the medication. Next slide. So voxelotor, developmental name of GBT440, which I may cross-reference, is a hemoglobin allosteric modulator. It's taken once daily orally and used to treat sickle cell disease, and it's classified as a first-in-class hemoglobin S polymerization inhibitor, right? So something quite novel. Next slide. It's a little bit of background on hemoglobin. It's a tetramer, 2 alpha units, 2 beta subunits, and it exists in 2 states, the relaxed state and the taut state. So it's the relaxed state that has a higher oxygen affinity. As more oxygen binds, it further favors this relaxed state, increasing its oxygen affinity to absorb oxygen in oxygen-rich tissues like the lungs. And conversely, in musculature, et cetera, where there's a lack of oxygen, the chemistry favors the taut state so that the hemoglobin can unload the oxygen. Next slide, please. So that whole phenomenon is known as cooperative binding, and this graph demonstrates that, and the Bohr effect as it's known. So specifically, one thing to focus on when we're looking at this is the left shift that is associated with increased oxygen affinity in oxygen-rich environments, which is that, on the left, as opposed to the right shift that's seen in acidic environments, which is the blue on the right. I'm not sure if you can see my mouse. Okay, next slide, please. So some fundamentals on sickle cell anemia: autosomal recessive and point mutation of glutamine with a valine at the 6th amino acid there, affecting its configuration and the chemistry. And this in turn makes the taut form unstable. So it's really that taut form that's a culprit of the whole disease. Next slide. So in oxygen poor environments, what happens is, just a refresher, the hemoglobin polymerizes, and it affects the shape of the red blood cells, leading them to sickle. And this new shape, this sickle shape, does not pass through small vasculature such as capillaries, leading to occlusion, the infamous states, acute chest syndrome, splenic sequestration, thromboemboli, and all the comorbidities that we all know too well. And then specifically the lower hemoglobin levels that are acknowledged to be associated with poor outcomes. So this being a target is thought to reduce clinical complications and mortality. Next slide, please. So how does it work? So voxelotor binds covalently and reversibly to the N-terminal valine of one of the alpha subunit chains, and it favorably partitions specifically to the red blood cell, actually 150 times red blood cell to plasma concentration. Next slide. And specifically, it doesn't inhibit oxygen release. So that's pretty important. Its binding modulates the hemoglobin oxygen affinity by stabilizing that relaxed state that we mentioned earlier. Next slide. So also importantly, we know that patients in infancy that have sickle cell anemia don't exhibit signs and symptoms of the disease. And the level of fetal hemoglobin that persists is 30%. Now, remember, the fetal hemoglobin has that higher oxygen affinity to absorb oxygen from the mother's blood. So essentially, we want something with higher oxygen affinity, or that's not going to necessarily compromise oxygen delivery in patients that receive this medication. Next slide. So in the phase 1/2 trial, it demonstrated favorable dose-dependent increases in hemoglobin oxygen affinity, with doses of up to 1,000 milligrams for 28 days and 900 milligrams for 90 days, associated with only low-grade side effects in patients with sickle cell disease. Next slide. So now we see 2 graphs, one on the left with purified sickle cell hemoglobin, and right with whole blood from patients with sickle cell. both of them showed and demonstrated that with increased doses, there is that left shift signifying that that increased oxygen affinity that we're looking for, with increasing doses being the red being the higher dose. Next slide. Also favorably in oxygen poor environments, it was noted that there was a delay in hemoglobin polymerization, excuse me. So also something quite practical. With increasing doses, the delay was more significant. Next slide. Looking at blood in poor oxygen poor environment, looking at the two slides, C is control and D is patient treated with the voxelotor, and we see significant decrease in sickling in patients with increased doses of the voxelotor. And also, as noted on the graphs there, that you can also see. Next slide, please. So in 2017 to 2018, there was a phase 3 randomized controlled trial in 12 countries, 60 institutions that evaluated the safety and efficacy of voxelotor. Patients were aged between 12 to 65 years old, randomized in 3 groups: voxelotor, 1,500 milligrams high dose, 900 milligrams, and placebo. They were stratified by age and concomitant use of hydroxyurea use. Next slide, please. Primary endpoint was percentage of patients that had hemoglobin response, which is defined as an increase from baseline of more than 1 gram per deciliter of hemoglobin at week 24. Secondary endpoints essentially looked at the lab markers associated with hemolysis, including indirect bilirubin level, absolute reticulocyte count, percentage of reticulocytes, and lactate dehydrogenase level. Also looking at annualized incidence rate of vaso-occlusive crisis in patients that were treated. Assessments were done periodically throughout the 24-week period. Next slide. So let's look at the picture. Next slide. So remarkably, looking at the higher dose compared to placebo on the right, higher dose being on the left. These are waterfall plots, and the area above the 0 point signifies the amount of patients that had an increase in hemoglobin response. Area below these, below the middle are patients that actually decline. So when comparing the red on the right to the high dose on the left, we see that with the increased doses, there's also a very significant rise in patients' hemoglobin level, which was 59%, and also, very importantly, approximately 3-fold decrease in patients that had hemoglobin decline. So that's also very meaningful. And right in the middle, essentially, was the 900 milligrams dose that was somewhere in between there, with 38% patients having a hemoglobin response. Next slide, please. Looking at the hemoglobin levels throughout the 24-week period, we observed that, or they observed that at 2 weeks, steady state was reached. And as expected, throughout the time, the higher dose of voxelotor led to consistent elevations in hemoglobin levels, which was also essentially dose dependent compared to placebo, which we see that patients actually declined. Next slide, please. Looking at secondary endpoints, essentially all markers improved, with indirect bilirubin level improving significantly, decreasing approximately 29.1%, percent reticulocyte count improving significantly as well, dropping negative 19.9, with also improved but non-significant markers looking at the lactate dehydrogenase level and absolute reticulocyte count. Next slide, please. Safety, most common adverse reactions were headache, diarrhea, nausea, rash, fatigue, and pyrexia. These reported following single dose of Accelerator in healthy patients and were noted to be mild or grade 1. Percentage of patients having any adverse events that were serious were similar in both of Accelerator and placebo groups. Next slide. So we know that the steady state was reached approximately after 2 weeks of initiation of the drug and sustained throughout the treatment period. Incidence of vaso-occlusive crisis improved, however, not significantly amongst the trial groups. And there was no evidence of impaired tissue oxygenation, which would be that risk that we were concerned about before. Next slide. So conclusion, treatment with Accelerator achieved rapid, significant, and sustained improvement with the higher dose of Accelerator at 1,500 milligrams, increasing greater than 59% in patients of that primary endpoint of rise in hemoglobin of greater than 1 gram per deciliter. And as far as concomitant hydroxyurea use, anemia improvement took place irrespective of baseline anemia severity or hydroxyurea use. Next slide. So it's a safe, effective, and well-tolerated hemoglobin S polymerization inhibitor, significantly increased hemoglobin levels, reduced markers of hemolysis. Findings are consistent with inhibition, indicating a disease-modifying potential. Thank you, everyone. Looks like I have a couple minutes for questions if anyone has any. Next slide. I can't hear anyone. Let me see something. Audio setting.
I have a question. So this,
Yeah,
this drug can be used without hydroxyurea?
Yes.
Correct. So it's a standalone?
Yes.
Okay, very good. Anything else? Any other questions or comments?
Yeah, Peter, I have a quick question.
Yes.
You indicated that there was no change in vaso-occlusive crisis. Was that represented in terms of patient liking scores for this particular medication? I would think that vaso-occlusive crisis would be the things that patients would worry about the most.
Yes, there was some decrease. The patients that receive Accelerator had an annual incidence per person per year of 2.7 with the higher dose and the 900 milligram dose versus the placebo that had 3.19. So there was a small improvement. However, it was not very significant.
Okay.
Based on the dose, at least.
Okay, any other questions, comments? If not, I'll turn it back to Dr. Witkin for concluding remarks.
So thank you all for attending. We hope you enjoyed our program. Thank you again to all of our speakers for the excellent presentations and to our moderators, Dr. Schmidt and Dr. Interisi. We want to invite you to join us at our next meeting as listed here for Meet the Fellows, Tips for Success for Residents on Tuesday, June 1st at 6 to 7 p.m. Next slide. And you will be receiving information from NYU about claiming your CME credit. So please look for that. Again, thank you, everyone. It was a great evening. I hope you enjoyed it.
Yes, we did. Thank you.
Thank you.